is between a tendinitis and a tendinosis. So with a tendinitis, it's an inflammatory condition, which doesn't often happen. They react to anti-inflammatories and they settle. When we have a tendinosis, there are no inflammatory cells. And this is where our problems come in. Now, a clear sign for a tendinopathy is morning stiffness. Very much like the plantar fasciitis, they complain the moment they put a foot out of bed, it's uncomfortable. And with a tendinopathy, exactly the same. A sad one is when a player heard a popping sound, then you should know there's a rupture. What they often come back and tell as a history is they thought somebody shot them or somebody threw a rock at them. And often they can still walk. And they are totally surprised and shocked if you evaluate them with the calf squeeze test and there's no action in the plantar dorsiflexion. Then they cannot believe that the Achilles is actually torn off. And that is one of your most reliable tests. If you put the patient down prone and you do the calf squeeze and the foot has to be able to plantiflex and dorsiflex, then if it can't, you know it's gone. And normally surgery is not so crucial to have done immediately, but with an Achilles tendon, the sooner they can operate, the less pulling back into the sheath happens and the more successful you operate. Okay, that brings us to knee and lower leg. I think a lot of us get to do with knee injuries in our practices, and diagnosis is very important for us to see if we can handle them or whether they must be referred. So let's have a look just at some anatomy pointers that I find very important and that we tend to forget. LCL is straight down, a cord-like, comes from the lateral femoral condyle and goes straight down to the fibular head. Okay, it's close to the knee without going over the knee. I even tell my patients just to use a normal cake roller. They also work. But you've got to, if you've got that pain on the talar tendon, you've got to loosen up that quad. Treat the pain and swelling locally. You tape to deload the pressure just below the patella. I'll show you one of those tapings for our last session. Rehabilitate, but initially no painful exercises. Very, very important to not train into pain. Here you can see where the popliteal sits. Comes from the lateral femoral condyle onto the posterior surface of the tibia, just above the soleal line. And it's very important. This muscle is one of the only muscles that can reverse its action depending whether it's in closed chain or open chain. When it's in closed chain, it pulls back the lateral meniscus with knee flexion and extenuates the femur in stance phase. So it is responsible for external